Felix, we are not on full screen mode. You'd like to put it later, or how's it?
Yes, I'll put it.
Good.
Technical team, once you give me the go ahead, exactly after 30 seconds, I'll start.
Yes, sir. Yes, sir.
Good evening, everyone. I, Dr. Sandeep Kumar, along with Dr. Kaushik Pandit, President-elect of Endocrine Society of India and Chief Patron of this program, welcome you all to this chapter of ESI Case Capsule. Dear friends, today Case Capsule is a very special one as one of the renowned endocrinologists, a very sought-after teacher and great researcher, is a faculty moderator for today's Case Capsule. And we welcome Dr. Nitin Kapoor from CMC Vellore, and he required no introduction in front of him. Even if I try to introduce him to you or give his credentials or achievements, any amount of the time would be short for that. In fact, while interacting with you, you've been saying that how every endocrine students want to listen to him and want to attend any academic program where you can learn from him. And you gave me the reference of recent in NBA program where he talked about the new types of diabetes mellitus. So thank you for consenting to be a faculty moderator, and we are really honored to have you here. And dear friends, not only this, this is a very special day today because he has been a driving force and one of the pioneers among this program. And today ESI Case Capsule is recognized as one of the sought after academic programs in endocrine academic in nations. And all credit goes to him and his team during his earlier tenure when he was handling this. And thank you for that as well, sir. And Dr. Felix Manoharan, DM, Senior Resident from CMC Vellore, would be presenting the case of lean PCOS today. Thank you, Dr. Felix, to be there. And as the tradition, we are having a student panelist who would be interacting and facing your questions, sir. We have Dr. Amreshwara from AIMS Vilaspur, Dr. Prathmesh from Kokilaben, Dr. Somin from SIMS Indore, and Dr. Ranita from the Kolkata. And thank you for all the student panelists and wish you happy learning. Kindly interact and keep your the video on unless there's a data limitation, because this is an opportunity where you can interact and faculty can come to know about you. And before I hand over the days to Dr. Nitin Kapoor, I would request Dr. Kaushik Pandit to please give his thoughts of wisdom to today's students and motivate them. Sir, over to you.
Good evening and a very warm welcome to all of you.
Endocrine Society of India takes great pride in arranging such meetings amongst the senior endocrinologist and the junior endocrinologist. It is a resource for everybody, the students as well as the senior endocrinologist, as a source of knowledge. And it is an opportunity for all of us to update ourselves. It is also an opportunity for ESI to get to know our younger colleagues, and would very much like all of you to join your own society in future in a short while. So without further ado, let me also tell you that this is a great opportunity for learning today from one of my very favorite teacher, Dr. Nitin Kapoor, who is a good friend of mine. And so happy learning. Thank you very much.
Thank you, sir. Sir, over to you, sir.
Thank you so much, Dr. Kaushik and Dr. Sandeep. It's truly an honor, and it's so nice to see this program that we started almost a year and a half ago has taken leaps and bounds and evolved over time. We know that the quiz prizes have increased. There's a book that is coming up out of this program, and it really gives me great pleasure to be back on this, and not as a host, but maybe as a moderator. But it's great to interact with students, and for all the students who've joined us not only on the Zoom platform but also online at the ESI website, feel free to ask anything. I think on the Zoom you can definitely ask questions directly, but at the same time, if there's a provision in the ESI platform that also can be used. So with this, I think we'll start and request Dr. Felix Manoran, who's our DM resident, to start with the presentation.
Good evening, respected faculty and my dear friends. So today I will be talking about a patient with lean PCOS and diabetes, a case presentation. So we'll go over the case. So this is a 22-year-old unmarried female who had presented with history of excessive hair growth and irregular menstrual cycles for the last 4 years. So currently she has been referred for newly detected diabetes mellitus with glycated hemoglobin of 7.1% with the above complaints.
Right. So in clinical practice, I think you will see a lot of patients with this complaint of excessive hair growth. And maybe, if you look at literature, 10% of the population of women are said to have excessive hair growth. So in clinical practice, in exam, you will definitely come across this in some way or the other. But maybe to begin the discussion, and maybe if I can start with Dr. Amar, uh, what would be the common causes of excessive hair growth that you think you would see in your practice? So I'll still ask the common, and then if you can tell me the uncommon also. But if you could list the top 6 causes or 5 causes that come to your mind in your clinical practice when you have a patient walking into your clinic with excessive hair growth, what causes will come to your mind?
Sir, first one, sir, idiopathic hirsutism, sir.
Okay,
Then, sir, PCOS, sir, primary PCOS, sir.
right. Apart from that,
Sir. And after that, sir, ovarian hypertrichosis. Very
that's an
rare, sir.
extreme form of PCOS itself. So, okay.
And, sir, apart from that, sir, it can be a part of ovarian tumors or androgen secreting tumors from the ovary or from the adrenal gland, sir.
Very good. So these are also important causes. And anything else? One other cause? As an
Apart from it,
endocrinologist,
sir,
we should not miss.
sir, insulin resistance, sir, hypothyroidism can also cause, sir, really, and hyperprolactinemia and even Cushing syndrome.
Okay, agreed, all of those. Any other endocrine cause which may present only with excessive hair growth? Cushing's, severe hypothyroidism will have a lot of stigmata of other symptoms as well. Any other endocrine cause related to the adrenal gland?
Sir, glucocorticoid resistance syndrome and CAH.
CH,
non-classic
yes,
CH.
non-classic CH. Very good. So that was the cause I was looking for. So great. You mentioned a lot of causes. If I was to change the order, maybe I just put PCOS first. Given that's really common. So if I get you 100 such patients, how many of them you think would have PCOS? Take a guess. It can be wrong. Majority. So say about 70 to 80% would be PCOS. So that would be most common. You mentioned one entity called idiopathic PCOS. Can you tell me a little more about that? What is that entity, idiopathic PCOS? It's a known entity. Is it because of some genetic cause? What is it?
Sir, in that it's a familial cause, sir. There won't be any. There is increased sensitivity of the androgens to the androgen receptor. So there is increased hair growth, sir, in the androgen
Right.
dependent area, sir.
Sure.
So usually the hormonal workup comes normal, sir,
Very good.
in
So
these patients.
that's something important because it's just not like in many other endocrine disorders where we say idiopathic is where we don't know the cause. Here, idiopathic hirsutism is something specific, and we have a cause. So good, Dr. Amar. So we move on to Dr. Prathmesh, and Dr. Prathmesh, if you tell me how common would be ovarian and adrenal tumors in practice? Again, if I get you 100 patients, you know, is that something common? If not, what number would you like to put in terms of percentage of all causes of excessive hair growth in your clinical practice that you would say? How many would have tumors?
Less than 1%, maybe.
Very good. So, literature says 0.2 or 0.3%. But are there certain places or are there certain, communities or ethnicities where some of these causes are more common? For example, if I take CH, so this is something commonly asked in exam. So where is CH more common in the world?
The world, they say, uh, in countries like Finland, sir, where
Okay, Central European countries. Anything else?
Ashkenazi Jews.
Very good. So Jews. So what is the percentage, Dr. Soman, since you mentioned the Jews? So
Ashkenazi Jews, I think 27, 22%.
No, that will be a lot. So 27% having CH in the population. So 3%, 3 to 4%, 3.7 to be precise. And Central Europe also has about 2%. So Dr. Soman, since you've come in, so what type of inheritance is there for this non-classical CH?
It is autosomal recessive, sir.
Right. So which populations would then therefore have more?
Those
India, if I talk,
those populations where consanguinity is
very good.
more common.
Consanguinity is more.
Yes.
So if I ask you more of a general knowledge and less endocrine question, then where consanguinity is very high in India? Top 3 states with the highest consanguinity.
Andhra,
Okay.
Andhra, Tamil Nadu is there.
Tamil Nadu is even higher than Andhra,
Yes.
but yes, good.
Yes.
So that's common. So are you aware of any other autoimmune, autosomal recessive disorders and endocrine?
Uh, uh,
So when a patient comes to you and tells about consanguinity, then your mind should tell you, okay, consanguinity, endocrine, I should have a few causes in mind.
yeah. Autosomal recessive, sir. There can be either like Wilson's can be there. Then
So how is Wilson's an endocrine disorder?
yeah, it's
I would
not
agree with
that.
the answer.
Yeah.
No, I would agree. Wilson's is an endocrine, but I want to know how.
It's a cause of secondary diabetes. No, that is hemochromatosis. Yeah.
But Wilson's is an endocrine disorder. So
Wilson's,
if
in case
doctor,
of when the hepatic involvement is there, at
Mhm.
that time the carbohydrate metabolism can be affected, and that is how.
no, Dr. Felix, you know some work done from Vellore. Wilson's is an endocrine disease.
Wilson's can present with diabetes mellitus, with
Not really, not so important. Diabetes is not. Then what else? Common. Which of the 6 or key endocrine organs would Wilson's involve?
pituitary, hypopituitarism,
Okay, something more important. Can cause hypopituitarism. I won't disagree with that.
and hypothyroidism.
Few case reports, both of hypothyroid and hypopara, but again, handful. Most common
Gonadal,
endocrine.
Gonadal dysfunction.
Anybody else? Ranita, Dr. Ranita? There's a case report published from Calcutta by Dr. Chitra Selvan, who's much senior to you. Wilson's, maybe sometime 2012. So Wilson's causing renal tubular acidosis and therefore causing osteomalacia. So we did a study in Vellore where we found that about 56% of patients with Wilson's disease have RTA, and osteomalacia is a very important component. They present with both proximal and distal, and large majority of them have mixed RTA as well. Anyway, so we're deviating a lot from the topic. So coming back to excessive hair growth, we discussed the causes, PCOS being more important. In exam, when you answer, it is little good that if you can classify your answer, the examiner will get more impressed. So, if you have to mention some organs, so you can say it could be either because of ovarian or adrenal causes. So if you classify it, you'll be able to give better answers. So in ovarian, you can mention about PCOS, you can talk about, ovarian tumors. In adrenal, you can talk about CAH, you can talk about adrenal tumors, and then you can talk about idiopathic. So that would be a little more scoring way of answer. But the second complaint that this patient has is irregular menstrual cycles. So maybe I would start with Dr. Prathamesh this time.
Yes.
So, recently we had the International Evidence-Based PCOS Guidelines published in 2023 by Professor Helena Teet from Australia. And that has very clearly defined as what irregular menstrual cycle actually means. So if I ask you what is irregular menstrual cycles, by definition, what would you say?
So in general, so it is classified according to the onset after menarche.
Very good.
It is within 1 year of menarche, any cycle which is more than 90 days, prolonged by more than 90 days, can be classified as irregular cycle. So between 1 to 3 years after menarche, we would say any cycle less than 21 days to more than 45 days. And after 3 years, any cycle which is less than 21 days or more than 35 days would be classified as an irregular menstrual cycle.
So good answer. Small corrections here and there, but I'm glad that you mentioned. So it's very important that when you talk of irregular menstrual cycles, you have to look at the age of the patient. I would disagree with the first point. You said within first year, some 90 days. Actually, they say within first year, after menarche, any cycle which can happen anytime, even 6 months of amenorrhea is not considered. So first year of after menarche, you just let it go. Agree with the first to 3 year definition and 3 years to premenopause. But then there again, there is this classic definition that most of your examiners would want to hear is less than 8 cycles per year, and then after menopause, if there is bleeding, after 90 days, then that is also considered. So this is a very clear definition, and hereafter, most of the publications talk about irregular menstrual cycles with respect to age of menarche. The patient that we have here is a 22-year-old lady, and so for her, irregular menstrual cycles is probably, anything which is either less than 21 or more than 35 days. Great. We can move on to the next slide, Dr. Felix.
So she had complaint of excessive hair growth on the face, limbs, and upper back for the past 4 years. It was gradually progressive with no features suggestive of virilization in the form of change in voice or change in body physique. And there was no clinical history to suggest hypothyroidism, hypercortisolemia, or any significant drug intake. She also underwent several sittings of laser therapy for hirsutism from her hometown dermatologist.
Right. So again, excessive hair growth, hirsutism is coming up. We did discuss the causes of hirsutism, and as endocrinologists, we are very clear that often hirsutism is because of increased androgens. But there is also an entity called the non-hyperandrogenic hirsutism. So, Dr. Somin, would you be able to tell me some causes of non-hyperandrogenic hirsutism? So, patient has hirsutism, but the androgens are perfectly normal. What comes to your mind? You have to unmute.
Yes, sir.
You did mention a few causes before, and you'll be able to answer if you think clearly.
Yes. So hypothyroidism, hyperprolactinemia can
Very
be
good. So if there's
there.
hyperlactin, the gonadal steroid should be low and still the patient can have.
Yes.
Okay, so tell me other endocrine causes in the same line. We can finish all the endocrine causes here.
Glucocorticoid resistance syndromes are also, it can
That will have high androgens, because that is driven by ACTH.
uh, acro can also,
Very good.
acromegaly can
Right.
present.
Okay, apart from endocrine causes, what is common that you would see in your clinical practice? You wouldn't see so many acromegalies.
Yeah.
So drugs.
Yeah, minoxidil and these.
So what are the drugs?
The drugs can be they can be the first generation progestins can be there.
Good.
Like Norgestimate and first generation progestins.
Okay, apart from progestins.
And
so again, common drugs that you will see in your practice. Hardcore endocrine medicines that cause, hair growth.
The also the
Estrogen antagonists like
the
clomiphene.
clomiphene citrate and
yes. Which is another drug which is used only by endocrinologists. Nobody else uses them. For an endocrine disease, the classic side effect is excessive hair growth.
that is there. But,
how do you manage insulinomas?
Yeah, diazoxide is
good. So diazoxide can also cause. Yes. What are the other side effects of diazoxide?
Diazoxide.
You've used?
So once, I have not used it that.
Right. So again, you're worried about water retention, especially in elderly patients with heart failure. No? Right. Yes. So we have to remember this condition called non-hyperandrogenic hirsutism as well.
Yes.
So moving on to another question, maybe for Dr. Ranita.
Yes, sir.
Dr. Ranita, so this patient you saw, 22-year-old, she's got PCOS. But, many times in practice, patients would have a younger sibling also. And the question they will ask you, doctor, my elder daughter already has PCOS, but, what is the chance that my younger daughter might also develop PCOS? Or what are the risk factors that, you should ask in history or will make you think that this is a patient who's at high risk of PCOS? In simple words, what are risk factors to develop PCOS?
Sir, genetic component is very rare, sir. Mostly it is autosomal dominant. Yeah. And what are the risk factors, sir?
Yeah, risk factors. So in the history, if I ask 1, 2, 3, 4, 5 questions and if all of those questions come positive, then I know this patient is likely to have PCOS. So we'll come to genetics in a while. I would disagree. It's not autosomal dominant, and I think there is a strong genetic component. So with that, one risk factor would be that if patient says my first degree relative has PCOS, that itself would be a risk factor. But any other risk factor that comes to your mind?
If there is excessive weight gain in adolescence, sir.
Very good. So that's an important thing. Rather, specifically,
And,
what has been shown is pre-pubertal obesity. If somebody has obesity, before puberty, so are they likely to have puberty early or late if there is obesity in the pre-pubertal stage? Early or late? So if patients have obesity, the puberty will be earlier. They're likely to have more estrogen.
Yes, sir.
Right. So that's another risk factor. Any other risk factor which is described classically as a risk factor for PCOS?
Sir, if perimenarchal, sir, irregular menstrual cycles, and the
they will have perimenarchal irregular menstrual cycles. So maybe just to complete the list, asking about birth weight. So there's a very strong correlation of low birth weight as well as high birth weight with future development of PCOS. Also, obviously, usage of drugs and the other causes like, if somebody is on valproate, likely to develop PCOS. So there are certain specific risk factors. I think in practice, what is most important is having first degree relatives, not only of PCOS, but also of metabolic syndrome. So if that history is there, that would be a high risk factor.
Okay.
Let's move on to our next slide.
Yes. So she had not taken any treatment for hirsutism for the past 6 months. And currently she has been detected with new onset diabetes mellitus just prior to the present consultation. There is no previous history of diabetes mellitus, and last glucose check was around 3 years ago. There was
Alright, so no previous, yeah.
no feature suggestive of any secondary forms of diabetes mellitus or history of prior ketoacidosis, and no history of osmotic symptoms or feature suggestive of micro and macrovascular complications of diabetes mellitus. There is
Right,
also
so
no
we'll just
family
hold
history of
on.
young onset diabetes.
Yeah. So maybe Dr. Amar again, if I may ask. So this patient has young onset diabetes, which is one of the associations of PCOS. From your reading, can you tell me what proportion of patients with PCOS are likely to have diabetes? Or take a guess based on your practice experience.
15 to 20%, sir.
Right, you're close. So about 10 to 12%, 12% on an average. But can you also list out other comorbidities that may be present? Now, if my patient is coming and telling me, doctor, I have diabetes and I'm thinking of PCOS, then I should ask other comorbidities also. I should evaluate. So, what are the other common comorbidities that are associated in a patient with PCOS?
Sir, patient will be having signs of insulin, severe signs of severe insulin resistance signs, sir, like
Correct.
skin
And
tags,
that's the
acanthosis
reason.
nigricans.
Very good. So, and that's the reason they have diabetes. Correct. I agree. What are the other disorders that they can have apart from diabetes?
Patient will be having usually the patients will be obese, sir. So
Yes, they will have obesity, can have obesity. Though we are going to learn that this patient did not have obesity, but yes, a large proportion of them can have. Agreed.
and
Apart from that,
there will be component of metabolic syndrome, like patient will be having hypertriglyceridemia, sir. Patient can have, sir.
agreed. Metabolic syndrome, definitely. High risk.
Hypertension and hypertension.
Yes, part of metabolic syndrome.
And
2, 3 other questions that I should keep in mind. Okay, this is a patient for high risk. Patient comes
hypothyroidism.
with menorrhagia. You've been managing a patient with PCOS for the last 10 years, and now she comes with menorrhagia and she comes with abdominal pain, some weight loss.
Endometrial cancer.
Right. Okay. So a couple of other things that we often miss in clinical practice is also, looking at the psychological aspect in this patient. That is a big component, which is there. Depression is very common. To complete the list, yes, the CV risk is high. Metabolic associated steatotic liver disease, more common obstructive sleep apnea. But yes, you mentioned most of them. So yes, we have to know these comorbidities. And now for this particular patient, she's got diabetes in young, and though with PCOS we presume this would be type 2 diabetes. Maybe if I ask Dr. Prasmesh, in your practice, when you have a young patient, 22-year-old with diabetes, her BMI we'll see later is only less than 23. What are the causes that come to your mind?
So in such a young onset of diabetes, we would always like to rule out type 1 diabetes. So
Very good.
the
Yes. Though she does not give history of TK, as Dr. Felix mentioned, but yes, type 1 diabetes is important. Second,
after ruling that out, sir, we have to rule out monogenic causes, MODY, sir.
is it? That's the most common. After that, could it not still be early type 2?
Early type 2 diabetes.
Yes, good. Modi, I would have kept higher up if we would have got a 3-generation family history or family history of young onset diabetes or consanguinity. But yes, early type 2 would still be top, even if it is looking like Modi, but that is more common. You will see more people with early type 2. So agreed, type 1, early type 2, and Modi. What else?
They may also be latent autoimmune diabetes, LADA.
Okay, could be. Another hint is this patient is thin. So what other type of diabetes you should screen for?
Pancreatic diabetes, sir.
Right. So the patient does not have any symptoms of abdominal pain, but still will you think of pancreatic diabetes?
So it might be also related to chronic calcific pancreatitis, which must have happened previously.
Okay.
We would not screen every patient, sir, but we would, if the other differentials are not positive, then we would like to rule that out, sir, as well. In
Right.
familial
So depends from institution to institution. So at our institution, we would screen every patient. Why? Because 30 to 40% of patients with pancreatic diabetes will be absolutely asymptomatic. They will never have steatoria. They will not have abdominal pain. The only manifestation would be diabetes. So if you miss, then you're missing out. Why are we so worried? What if I miss that diagnosis? I anyhow give this patient insulin or some medicine, and glucose values are good. But what is my worry if it was an
higher
FCPD and I
risk
missed
of
it?
higher risk of hypoglycemia because the glucagon is also not there here, and
Okay, one. Any other risk, especially if they have FCPD?
mm,
Pancreatic carcinoma.
Pardon?
Pancreatic carcinoma.
Right. So since you mentioned that, can you tell me the number? How common is it? I get you 100 patients with fibrocalcific pancreatic diabetes. How many are likely to develop pancreatic cancer? With controversial literature, but as long as you can tell me.
10 to 20%.
So even more. So some literature talks about 30%, one third. That's a very high number. You miss a type of diabetes and that patient lands up with cancer later on. That's not good. And therefore, the recommendation is that every year you should screen that patient with CA19-9. And we've seen quite a few pancreatic cancers in patients with FCPD. So yes, I think so. Yes, the list is complete. However, since clinically there is no DKA and this patient is, having a PCO kind of a phenotype, we are thinking of early type 2, but yes, we should investigate for these other causes. Move on, Dr. Felix.
Yes. So she had irregular menses since menarche and had menses for 5 days every 2 to 3 months, but she's currently not on any medication for the same. And there is no other significant past personal or family history.
Right. So here comes family history, and I believe Dr. Anita, you were talking about it earlier. So if I ask you, is PCOS a genetic disorder? Because earlier I did mention that family history is an important risk factor. And if you actually look at literature, they say that about 70% of PCOS pathogenesis is attributable to genetic components. How they get this data is they look at twin studies, and they look at the difference between monogenic and as the genetic makeup gets more different, they see that the PCOS phenotype keeps coming down. But as in monogenic risk, they will be very high concordance. So how would you answer that? Is PCOS a genetic disorder? If yes, what kind of genes are involved?
Usually genetic risk factors is account for less than 10%. And the genes usually sir CYP11A1, the insulin gene, and LH, CGR, THADA, and sir DEN-D1A, FSH beta. These are the receptors. These are the genes actually, sir. There are more genes usually.
Right. So again, I think trying to develop a good habit to get a very good mark in exam, it's always good, if possible, to classify your answer. So if I
Okay.
was you, what I would do is I would say there are several genes involved with insulin resistance pathways, ovarian steroidogenesis pathways, adrenal pathways, gonadotropic dysregulation pathways. So like this, several genes are involved, and then could name a few definitely. But what is really important when you answer about genetics of PCOS is that it's more of an epigenetic problem than genetic. And then, any idea what are the epigenetic problems associated with PCOS?
Uh, s- no, sir. The DNA methylation problem is there, sir. Some.
Where so
Uh,
hypermethylation in the granular cells of the ovary is classically described. And though it is a multigenic disorder, there is a very, very strong epigenetic factor in PCOS. So and family history is indeed very, very important.
yes, sir.
And so that's about this patient. So before we move on to examination, there are certain types of phenotypes that are described in literature. Maybe Dr. Somin, if I may ask you.
Yes.
So are you aware of the 7 phenotypes that are described with PCOS, and what are they?
Sir, the phenotypes, one is the classic phenotype, sir.
Yes.
That contains all the 3 components.
Very good.
That is the oligoanovulation, as well as the PCO morphology, along with that, the hyperandrogenism.
Right.
That is the classic one, sir. Then, sir, there is type B is there, sir. Phenotype B, which basically goes for the national, the NIH criteria. That
Yes.
is only the hyperandrogenism and the oligoanovulation, not the PCO morphology.
Very good. So you rightly mentioned, so based on different permutation combinations, these 7
Yes.
phenotypes are described.
Yes.
You very importantly mentioned the classical, which is not only the classic, but also the most common phenotype. So you have to know all these types. But if I ask you a specific question, which is the rarest of these phenotypes? Which are, there are certain studies which say that this phenotype and this phenotype were not found in studies. Are you aware of that? Which are rare, so that you're not going to see them in your clinical practice so much, or if you see that rare combination, you might think of something else rather than PCOS.
Sir, the non-hyperandrogenic type of PCOS, the type D.
And correct, that's correct. One more time. Type G. So type G is where only
Yes.
there is presence of oligo and ovulation. So that is also something which is said to be very, very rare. Many studies are also showing that this is not existing. So very good. So you all have to know these 7 types of phenotypes. So we can move on, Dr. Felix.
Yes. So on clinical examination, the patient had a height of 159 centimeter, weight of 56.4 kg, with a BMI of 22.3 kilogram per meter square. There was no pallor-icterus clubbing, cyanosis, lymphadenopathy, or pedal edema. And she had a BP of 126/78 with a normal pulse rate.
Right. Any comment on the BMI, Dr. Amar?
BMI, it belongs to the BMI. It's normal for the Indian phenotype, sir.
So what is overweight?
Overweight, sir, for Indian phenotype, sir, 23 to 27.5, sir.
Anybody has any other definition for overweight?
23 to 24.9, sir.
Okay, yeah. As long as you know your references, that's fine. So yes, the Endocrine Society of India guidelines talks about 23 to 24.9. But yes, 27.5 is also mentioned by some papers. And as you rightly mentioned, this patient has a normal BMI. Next slide.
She had hirsutism with a modified Ferriman-Galway score of 21. She had no thyromegaly, and there was no acanthosis nigricans. In the rest of the general physical examination and systemic review.
Right. So maybe Dr. Amar again, we are talking of Ferriman-Galway score of 21. You've used it in clinical practice?
Yes, sir. We use it.
Right. So this is modified Ferriman. So there must be something which is unmodified. Can you tell me the difference between modified and unmodified?
Not aware of.
No problem. So at least you tell me what is modified, how many sites are screened? So there are about 9 sites. And how many marks do you give for each site? 0 to 4. So you can get a maximum score of 36. Are you aware what is abnormal, normal?
Sir, more than 8 is abnormal, sir.
Are you able to tell me severity based on the score? If I say severe hirsutism, that will be more than?
26.
Not 26. This is moderate. So 17 to 24 is said to be moderate. More than 24 is said to be severe. Right. So anybody else knows the difference between modified and non-modified? Anyone? So again, you have to know that because many of your examiners would have probably used a non-modified one if you get an old exam. Yeah.
The sideburns are not taken, the arms, the forearms are not taken in that modified.
Apart from forearm, one more please. So basically that had 11 sites instead of 9.
Yes.
So one was forearm, the second was?
The sideburns, and
Lower legs.
lower legs. Yes, yes.
Right. So I think this is a very commonly used tool in exam. You should be able to mention all the 9 sites. You should be able to tell, how you grade it,
Yes.
and ideally, especially if you have a female patient, and if you're a boy, then you should be able to show it in a card and be able to still assess it properly during exam. So this is something important. So we move ahead.
So we did a baseline laboratory investigations, and it showed a fasting glucose of 132, postprandial glucose of 212 milligram per deciliter. She had a glycated hemoglobin of 7.1%. Prolactin, testosterone, follicular stimulus, FSH, and LH were normal. The TSH was 3.2. Total thyroxine was 5.7, which was in the normal range. And free thyroxine was also normal. Her 8 serum cortisol was 15.1, which was normal. And her electrolytes were also normal. She had a fasting LDL cholesterol of 136 milligram per deciliter. And ultrasound abdomen showed polycystic ovarian morphology.
Great. So maybe I ask Dr. Prathamesh my next question. Is there any other investigation you'd like to see?
According to the newer guidelines, maybe we could have also done an AMH, but if an ultrasound is also there, already there, then maybe AMH was not required. So we also sometimes clinical practice, we also do fasting insulin to see insulin resistance in PCOS patients. But
Very
The
good.
basic
So,
screening
yeah,
test we would do, like is this if this is female patients, and basic screening test, pregnancy should be ruled out by beta HCG, then CBC, LFT, urea creatinine, and ESR CRP we might do to rule out any chronic inflammatory state.
also 17 OHP. So
very good. So I was looking for 17 OHP. Now that since you mentioned AMH, can you tell me something about AMH in PCOS, Dr. Prathamesh?
So AMH as a criteria has just come up in the recent
Yes.
consensus guidelines, which says either a polycystic ovarian morphology or a serum AMH more than 3.5 nanograms per ml can be used for diagnosis of PCOS. The first two criteria would be the same, sir: clinical and or biochemical hyperandrogenism and oligoanovulation. Any two of the three mentioned, sir.
Very good. So in the same line, can you mention, as in the guidelines, they've also mentioned that AMH should not be used in DASH.
Adolescents, sir.
Very good. Yeah, so that's an important thing. Yes, AMH has come up. Elevated AMH is associated with PCOS. Not a very, either a sensitive or specific test, but yes, as an add-on is helpful. So, Dr. Radita, you mentioned CBC. How would you justify to me that CBC is very important for her? Dr. Anita?
Yes, sir.
So you mentioned CBC, right? I
Yes.
agree with LFT because they could have massive, but CBC?
Because these patients might have, sir, irregular menstrual cycle, so they might have amenorrhea sometimes.
Very
Like,
good. One more reason, low
uh,
hemoglobin. One more reason.
If they're on treatment, sir,
is there any
On treatment, so
with metformin, sir.
so how does CBC help? B12. You're talking of MCV being high. Is that okay? That's okay. How does platelet count help?
sir, for FIB4 index calculation or
Good. Correct.
APL?
Correct.
Yeah.
Right. Are there any special indications, Dr. Anita, in the same line, if you can answer? When would you like to do these tests? Are there any specific indications, specific timings you will tell this patient to do at this time of the month, or if they're on certain medications? What are the precautions before you send for the tests?
Sir, if they are on combined OC pills, then it should be stopped 3 months before. It should be stopped for minimum 3 months. Then we should go for test.
Pardon, sorry, I didn't get you. So you said stop for 3 months. What to stop?
Hormone pills if they are on.
Very good. But if they're not on OC pills, is there any particular time in the cycle that you'd like to assess these hormones?
The day 2 to day 5.
Very good. Early follicular phase.
Yes,
That
sir.
is something that you can tell. We see the ultrasound is showing polycystic ovarian morphology. In your guidelines has come up with some new funny terms, FNPO,
Yes, sir,
FNPS.
FNPs.
So what is FNPO, Dr. Anita?
The follicle number per ovary is more than
Which
equals
should
to
be
20, more than equals to 20 in each ovary,
very
and
good.
follicular number per
FNPS.
section is more than equals to 10.
Any other criteria? One
Each
more.
ovary and ovarian volume more than
Fantastic.
equals to 10 ml.
Very good. Correct. So you have to know all these terms as well because the new guidelines are quite in vogue. So we move ahead, Dr. Phillips. Next question. Next slide.
So we did a body composition analysis as
Yeah,
she
maybe just let the slide be there, and maybe if I request Dr. Somin, can you interpret what you say?
Yes. The total body fat percentage is 41.1, while
Which
the
is good, bad, ugly.
sir, it is higher. It is on the
Right.
higher side.
So
And
if I knew the cutoffs, I can say it is high or low. But suppose I did not know the cutoffs, is there any other information that you can see next to that which helps you? What is that YN and AM mentioned there? This is from a DEXA scan. So YN is like when I compare it to a young normal person. So
yes.
it is like telling me a T score, whereas AM is like a Z score. And I see that as compared to a young person, she is herself young, but it is quite high, 75. So normal body fat should be in women. Again, controversial if you can tell a reference.
25%.
Right, that would be for men. For women, about
50
30.
to
Some
20,
say
25 to 30.
correct. So again, you can refer to the ESI guidelines, Endocrine Society of India, 30 for women, 25 for men. Right. So the fat is high. What else can you interpret from that? So many values there.
So then the android to gynoid ratio is 1.02. So it is said that the android type of obesity is more of a risk factor for the PCOS, as it is it has more of visceral fat, and it is in the anterior abdominal wall it is deposited. It is more metabolically active also, and the contributes more to insulin resistance as well.
Very good, Dr. Soman. So that's another point. Good. Anything else that you see?
So trunk to limb fat ratio is 0.82. So so there is it doesn't have a typical like obese phenotype is not there, like a Cushing's or a central obesity is not there.
No lemon on stick. Right. Next.
Yeah.
How do you interpret the VAT area? Normal, abnormal. Is that important? Right. So it's important because many times total fat may be high, but then if there is more subcutaneous and less visceral,
visceral.
the visceral fat is more important. So estimated VAT area, if you look at definitions, anything more than 100 is said to have a very high risk of CVH. Your odds is around 2.2. And the other important thing that I really wanted to highlight here is the appendicular lean by height square. Have you come across that sometime in any definition that you may have read, Dr. Soman? Appendicular lean by height square. How do you define sarcopenia? So sarcopenia is also something which is important from recent advances paper, but in clinical practice as well. And in sarcopenia definition for Asians, they say that value of appendicular lean by height square less than 5.4 is suggestive of low muscle mass. So this patient actually has sarcopenia, she has obesity, but the biggest irony is that her BMI is normal, 22. She was a very well-educated girl, and when she came to me, her first question was, doctor, I have normal weight and I thought I could eat everything, and now I have diabetes, and your dietitian has given me so many things to not eat. And she said my weight is normal, why should I restrict my calories? So that's how body composition really helped us, because if you can show that even if your weight is normal, your body fat may not be normal, and you need to put on muscle. So that's how body composition is helpful. Anybody else has any doubts on body composition? Or we can go to the next slide. Okay. Yeah.
Y
Yes,
and
Dr.
AM,
Amara.
sir. So please do
Yes.
elaborate on
So
the Y and AM, sir, because
right.
it's showing 75, sir.
Yes. So YN. So just before we get into this, you know how we interpret DEXA scan for BMD? You know T score and Z score, right? So what is T score?
That is called the bone mineral density, which is corrected for the which is for corrected for the teenage
Young,
young adult.
young adult. Perfect. Very good. So similarly, YN stands for young normal. So when I compare this patient's body fat percentage to a young normal person, this person will come in 75th percentile. So that will tell me if I have 100 people who were young and I would be comparing this person's body fat, this person will be in the top 75th number. So this patient has high body fat. If I compare to an age matched person, another 22-year-old person, then it is not that bad. Having said that, in any adult, you can say that anything which is above 30 is bad. And having a BMI of 22 and still having 40% fat is definitely alarming. So that's YN and AM. And similarly, when you look at the muscle mass, it is so low as compared to a young normal person, 7 percentile. So it is clearly telling you that even though this patient has normal BMI, her BMI is mainly made of fat and very low muscle. So this is the phenotype of normal weight obesity. You can also call it a sarcopenic obesity. Right. Okay, good. We move ahead. Slide 11.
So finally, we had come into a diagnosis of normal weight obesity with hirsutism and with anovulatory menstrual cycles, and with the primary diagnosis of polycystic ovarian syndrome, along with type 2 diabetes mellitus.
Right. So essentially, we have ruled out all the causes that we, discussed as causes of hirsutism, which are differential diagnosis for PCOS. But maybe very quickly, uh, Dr. Prathamesh, if you could tell me the differential diagnosis of PCOS. So PCOS is one of the cases that is often kept in the exam, as hirsutism or some kind of discussion. So then often the examiner will ask you the differential diagnosis. We already discussed the causes. Can you just tell me the top 5 differentials of PCOS? Because it's a diagnosis of exclusion, so you have to rule out those 4 or 5 causes. How will you put it, Dr. Prathamesh?
Hypothyroidism, hyperprolactinemia, non-classic CH, ovarian or adrenal tumors, and maybe idiopathic hirsutism as well.
Fantastic. I just add on glucocorticoid use or endogenous Cushing's also, but very, very good. So last thing that you can also keep is drugs. That is something common in practice. So again, in a short case or in a spotter, you will have very less time. So if you have these 6 things in your mind, then you will quickly also mention that I'd like to take history of drugs, and then it just completes the list. But very good. So we move on to the next slide. I see we are running short of time, so let's go. I think you have 3 or 4 more slides, I believe.
Yes, sir. 3 more slides.
Yeah.
So in management, we advised her lifestyle changes to stop sweets and sugar intake and to increase protein in diet and
Right.
decrease fat and carbohydrates, along with daily exercise of 30 minutes per day, along with resistance exercises.
Right. So I just like to reiterate here that, again, this patient had normal BMI. So there is a great utility of doing body composition. Maybe later on when you are practicing in your wherever you go, time would be that maybe 5 to 10 years, everybody will be doing body composition. So it's good to learn how to do it and how to interpret it. Next slide.
She was started on metformin, sustained release, 500 milligram twice daily for diabetes. She was also started on, in view of her hirsutism, she was started on an anovulatory cycles, started on oral contraceptive pills, combination pills from day 1 to 21, along with tablets spironolactone 50 milligram once daily for hirsutism.
Right, Dr. Soman, this is an important slide.
Yes.
So they often ask in exam. So how do OCPs actually help in PCOS?
Sir, in case of there is increased LH is there and unopposed estrogen action is also there. So
Very good.
the thing is that whenever we give OC pills, so that will suppress the LH. Once that LH is
What component of OCPIL will suppress the LH?
the estrogen component. As
Progesterone.
okay. Yes,
Right.
sir.
Correct. And that's right. So LH is going to be reduced. What else
Yes.
will it reduce?
Sir, it will also the ethinyl estradiol, the estrogen component will also
Yes.
increase the SHBG.
Very good.
And
that's also a very important mechanism.
That will bind to the androgens and reduce the free testosterone levels as well.
One more property that helps any enzyme is in
5-alpha reductase inhibition by progestins also occurs.
Yes, very good.
5-alpha reductase type 2.
Are there certain clinical features of PCOS where OCP is very helpful? Not helpful for everything, but what it really reduces? Does it reduce the PCO morphology or?
Sir, it reduces the hyperandrogen, the hirsutism part as well as the anovulation. These
Very
are
good.
the two things that
maybe acne, the whole of that hyperandrogenism.
Yes.
Very good.
Yes.
That's true. There's also metformin here. So Dr. Somin.
Sir,
So metformin.
Yes, sir. Metformin is, sir, not given for the weight loss purpose, but since insulin resistance is central to the pathogenesis, so because it causes reduction in the hepatic glucose output, so because of that, the hyperinsulinemia is also reduced. The insulin secretion is reduced. So the insulin resistance is slightly tided over, and insulin reduction also takes place. So that will also help in reducing insulin resistance, as well as the SHBG also will go up.
Right. But a more obvious answer here would be this patient has diabetes.
Diabetes, yes, sir.
So
yes.
this patient definitely needs an anti-diabetic agent. But I agree with you if this patient did not have diabetes. But is there any advantage of combining OCP with metformin? Does one help the other or doesn't help? Or? So metformin also helps to reduce hirsutism, but what is said is that when you combine it with an OCP, the side effects of metformin are said to be reduced. So Dr. Ranita, when in practice I will use letrozole as a first line management for PCOS?
Sorry, sir. What is the question?
When in my practice will I use letrozole as my first line treatment for PCOS?
So for ovulation induction, we usually prefer
Very good. So infertility being the primary problem, I'll use that. So great. How long should I wait for spironolactone to work? What should I tell my patient? 6 months. Very good. Why is this 6 months? Why not 3 months? Why not 9?
Hair cycle is 6 months.
Very good. What are the phases of hair cycle?
2 phases, anagen, telogen,
catagen.
I say 3.
Catagen, yes, 3 phases, sorry.
And then if you can correct the order. Okay, so sometimes examiners go into this physiology also. So ACT you remember, but you have to know these phases also. Move on to the next slide.
We asked her to review after 3 months.
So we discussed that 6 months is something which is required. But again, maybe 1 or 2 more questions before we close. What is, you heard of so many GLP-1 RAs now, they are flooded in the market, very effective for weight loss. If I ask Dr. Amar, can you use them in PCOS? Your patient comes and says, Doctor, my neighbor is using Manjaro and this and that, and she's lost so much weight, her PCOS is gone. Are there any studies to say GLP-1 RAs can be used in PCOS? Not approved yet, but
it can be used, sir. Finally, the insulin reduction will happen, sir. So that insulin resistance will be reduced, sir. So which will further reduce the effect on the ovaries. That's via IGF-1. The IGF-1 will be reduced, sir. So IGF-1 reduced will reduce the hirsutism, sir, by effect on the ovaries, sir.
Absolutely. Right. So basically, you can answer yes, there is emerging evidence, not yet in guidelines, but yes, if there is another indication and patient is not planning pregnancy, then you can use. How long? How much time before pregnancy you should stop this? Say tirzepatide.
3 months.
What does the insert say? Maybe next time you prescribe tirzepatide, you will pull out the insert yourself and see. So 3 months was when we were doing the trials, but the guidelines for the insert has come something later. Last question to Dr. Prathamesh. What is the role of myoinositol? Any Indian study?
Not aware of any Indian studies, sir, but it is supposed to be helpful, but lesser than metformin, sir. So clinically, it is only used, mostly used here, but
Okay, so Indian studies are important for exams. So there's a paper, I think, by Madurai Medical College. Look it up, published in Clinical Endocrinology, good journal. Should know. They showed it was useful, but you have to know the mechanisms and whether it's more useful in combination, alone, how does it work? Need to know. I think this was your last slide, Dr. Felix?
Yes, sir.
Right. So I think we stop here, but I think you all have answered extremely well, and it was a learning session. Good. Over to Dr. Sandeep.
So thank you. And it was truly a masterful session conducted with such a ease and clarity. And I personally have gained a lot, and I'm sure students have learned immensely as well from this session. And in fact, sir, other day we had called Dr. Yajnik to FMC Pune, and I'm reminded of YY paradox. And student would be aware how this paradox way back explained that our population is having a higher fat with lower BMI, and that possibly is a foundation for normal weight obesity and also a sarcopenic obesity. Very beautifully discussed, sir. Thank you, sir, as usual. And we thank you for teaching us and our students. And now we come to one of the exciting part of the ESI case capsule and the quiz. I'm sure students are waiting for that because there are a lot of cash prizes to be won, and we have a cash prizes for top 3 winners. And soon I will be sharing my screen. So get ready, and all of you are aware now how to access your quiz, and we will be conducting it on menti.com. So, okay. Okay. Okay, so dear students, so we come to the basically quiz part of the ESI case capsule, and by this time, all of you are aware that we conduct it on this platform, which is www.menti.com. It can be accessed very easily. You simply scan this QR code, you will get access to the quiz, or you go to www.menti.com, enter this number code, and you will gain access to this quiz. And this number code would be displayed in all the subsequent slides of the quiz. So don't worry, if you happen to log out, you can easily access your quiz again by simply entering this number QR code. And we wait for a few seconds, but before that, let's clarify the rules. It's a repetition, but it's very important to clarify the rules. The most important of that is that you need to have two smart screen devices for this. One on which you would be seeing this quiz right now. You're viewing my this screen. That is one just for seeing the question, and you require another smart screen devices like a smart screen phone generally, and from where you can attempt the answers. And it's very important to remember here that we are not looking for the correct answers. We are also looking for the fastest correct answers. So remember, even if you make all the answers correct, you may not be the winner because this platform utilizes the algorithm where automatically the fastest and correct the answers are chosen, and that person becomes the winner, or he is on the top of the number. The numbers are given, and he remains on the top of the list. And need not to mention, decision of the quiz master would be final. And yes, we would be giving you the references. Be stick generally to your Williams because that is the main thing for the endocrine resident. But yes, in the few of the question, we would be referring to some good articles or text as well. So we wait for a few seconds till all of you are ready, and I see a lot of thumbs up. So in next 30 to 40 seconds, we will begin with today's quiz. So very good. We have a lot of people, and already we have touched almost 60, and slowly this number is increasing. So as said, there are top cash prizes to be won for top 3 winners, 10,000 rupees for the number 1, 7,500 rupees for number 2, 5,000 rupees for number 3. And the time is very important here. And remember that it is the fastest finger which would matter at the same while answering the correct question. So we have already touched 60 people, and I think we are good to go in next 10 seconds. So dear friends, we begin with today's quiz, and here the question number 1 would be shortly on your screens. So functional hypothalamic amenorrhea is not associated with, so your options are with increased CRH, ACTH, cortisol, hyperleptinemia, increased ghrelin. So which one is the correct answer? Which is not seen in functional hypothalamic amenorrhea? So I think this is an easy one to start with. So correct answer, I'm sorry, many of you could not answer it correctly. So basically hyperleptinemia is not a feature of functional hypothalamic amenorrhea. It is a hypoleptinemia. And please, go back to that typical understanding of athlete, ballerina dancers, and people who stress, anorexia nervosa. These people may have a hypothalamic amenorrhea. Basically hypoleptinemia is the feature of functional hypothalamic amenorrhea. And it has been seen that in functional hypothalamic amenorrhea, there can be increased stimulation of ACTH adrenal axis, cortisol axis, and however there is no disturbance of the cortisol diurnal rhythm, and there is increased ghrelin which is seen in functional hypothalamic amenorrhea. And again, this question comes directly from your Williams 15th edition, and it's good that from after this quiz you can go and refer to all the questions from this book. So just to have an understanding, we can have a quick check at the leaderboard. Nothing to worry. People who are at the bottom of the list, don't worry. You have a lot of option to catch up, a lot of opportunities to catch up. Just remember, time would be very, very important. But anyways, Dr. Varun, Ayush, Dr. Raghavendra, Dr. Himanshi, Dr. MX, Prathamesh, they are leading. Dr. Felix, who presented, he is also there in the list. So wish you all the best. And people who are at the bottom need not to worry. You have a lot of opportunities to catch up. But remember that speed would be very important while giving the correct answer. So with this, I think we can go to question number 2, and question number 2 would be there shortly on your screens. So clitoral index greater than dash is abnormal and correlates statistically with androgen excess. So this is important clinical thing. And when we see the degree of hyperandrogenism, once the hyperandrogenism is more, so you can have more. So options are 25 millimeters square, 35 millimeters square, 45 millimeters square. So which one of this is a correct answer for a clitoral index greater than which denotes androgen excess? The correct answer, most of you could answer it correctly, and that was an easy one. It is a 35 millimeters square. So it has been seen rather than length, it is a clitoral index which should be utilized for advanced degree of androgen excess, and where we take a sagittal diameter and transverse diameter, multiply it, and if it comes to be more than 35 millimeters square, it is said to be it is said to relate statistically with androgen excess. And many of you could make it this correct answer correct. And again, this was directly from Williams, and that book again is very important. So question number 3 is here on your screen. The source of testosterone in reproductive age women is, and again a simple one. So that is a basic when you enter the endocrine training. So direct secretion by ovary is about 2/3, peripheral conversion is 1/3. That is one option. Or direct secretion by ovary is 1/3 and peripheral conversion is 2/3. So in the reproductive age group women, which is it true regarding the source of testosterone? So that sad situation. So many of you could not make it correct. In fact, that's a basic when we talk about androgen production in the women. So direct source of is from the ovary is about 1/3, and peripheral conversion is about 2/3 from mainly from the skin and adipose tissue. And again, it is in the initial part of your this chapter when you read the androgen excess in your Williams. So anyways, wish you all the best, and people who are at a close fight, please catch up, and remember time is very important. And now we can proceed to question number 5. So the question says traditional guidelines to investigate further whether neoplasm of ovary, traditional is very important, are that are it's a neoplasm is a source, maybe the source from the ovary or adrenal, and what are the cutoff use for these hormones? So is it a testo more than 2 nanogram per ml, DHES more than 8 microgram per ml, or testo more than 1 nanogram, DHES more than 6, or testo more than 3, or DHS more than 10? And the correct answer for that is number one option, testo more than 2 nanogram per ml, DHES more than 8 microgram ml. And it should be remembered, it was discussed during the presentation also, where these values may, that is very important to remember. Traditionally, it has been suggested that these value may give you information that probably you may be dealing with a neoplasm from the ovary and adrenal. But it is very important, the catch point to remember here, and which is also explained in your Williams, that it is not the rule. It is there are a lot of exception to this, and three exceptions need to be remembered. Number one is there can be a tumors which secrete the androgens which are other androgens, because other precursors are secrete, like androstenedione can be there. Another is because the tumors generally secrete the androgens which are episodic, so you may require multiple measurements. The time of cross section at which you are measuring the androgens, that time you may be getting a lower androgens. And third thing you should remember that even in the people with the neoplastic lesions, you may still get a lower level of androgens. So this should be remembered. But yes, a traditional teaching or traditional value, this is good idea to remember as an endocrine student, that more than 8 DHES microgram per ml or more than testo more than 2 nanogram per ml may point towards a neoplastic etiology. But if you get a lower levels of these hormones, still you should consider in appropriate setting, and clinical information might be very important. Short duration, hirsutism, virilization in a shorter duration, these may be little telltale signs which may point towards a neoplastic etiology. But yes, you should also remember this constitute less than 0.5% of all the patients whom you may encounter in such a clinical setting. We can have a quick check of a leaderboard because we are almost halfway through, and we have a Dr. Prathamesh, who is leading here. But nothing to worry. Dr. Raghavendra, Himanshi, Dr. Saurabh, Raveen Thomas, Dr. Somya, Ayush, you are in a close fight, and you have a very close gap between the points which are displayed here. So don't worry. There's a lot of opportunity to catch up. Remember, while answering the giving the correct answer, remember on the time as well. So I think we are good to go to next question, and next question is here on your screens. So the question says, which of the drug used for hirsutism has maximum average Ferriman-Galloway score reduction? Again, it's very simple from your Williams. So out of these options, we discussed it: OCP, spironolactone, metformin. Over the 6 months, which one would have a maximum reduction in Ferriman-Galloway score and average? So the correct answer for that is, okay, so again, I'm sorry, many of you could not answer it correctly. So it is seen that anti-androgen spironolactone has a maximum FG reduction over the period of 6 months. And it has been seen in the studies, you refer to the studies which are quoted in your Williams as well, that you can see reduction to the tune of about 38%, whereas with OCP, you can have a reduction to the tune of about 27%. And even metformin, you can have a reduction of FG score by about 18%. So that is important clinical thing to remember. And we can now go to the next question. So anyways, wish you all the best. We are towards the tail end of the questions of today's quiz. So people, please wake up and remember, time is important. And we have the question here on your screen. So question says, this is very important, interesting question. LH is elevated in the PCOS, that is understanding. So LH to FSH ratio is not required for diagnosis of PCOS. That is known to us. But even if you try to use, if you try to use the LH to FS ratio, it would be useful in which of these kind of the PCOS, obese PCOS or non-obese PCOS? I'm trying to ask you, the LH is elevated in which form of the PCOS? Oh, so basically, most of you could not answer. Very few of you could answer it correctly. So correct answer is non-obese PCOS. Remember, LH to FSH ratio is not a mandatory criteria for diagnosis of PCOS, but it has been seen that people with the patients with PCOS may have an elevated LH. However, it has been seen that obese girls with PCOS may not have a significant elevation of LH. few of them. Why? Because it has been seen that you should, recall to something. It is also referred in your Williams, and I refer you to this endocrine reviews of 2024, where it has been extensively discussed very beautifully, and they have invoked something like a male obesity related secondary hypogonadism. They are invoking the FOSH, female obesity related secondary hypogonadism, and they explained various mechanism how the insulin resistance and various other mechanism lead to the reduction in the LH level in the obese kind of the phenotype. So the elevation of LH to FSH ratio would more be seen in the non-obese kind of this PCOS phenotype, and this information is very important from your point of view, because this help you understand the pathophysiology of various phenotype of obesity, the PCOS and obesity syndrome. Okay, so with this, we go to the next question and a quick checkup of the leaderboard, and this is settling down. I think there's a close competition between Dr. Ayush, Dr. Isha, Dr. Pratmesh, Dr. Himanshi. Very close competition. In fact, wish you all the best. All of you can top 7, 8 winners. All of you can catch up and still in the next question. So wish you all the best. Remember about the time, and the next question is here on your screen. So question number 7 is here. So severity of hirsutism correlates with levels of androgen. This statement is true or false? So this has been discussed by Sir during the presentation, and so if you have a higher androgens, do we have a higher hirsutism? So this is a false statement, and I was expecting 100% of you should have answered it correctly, but sadly many of you could not make it correct. So it does not. And remember, sir has already discussed with you normal with the hirsutism with the normal androgen, idiopathic hirsutism. So there are a lot of mechanism. You go and read your Williams, like receptors may respond differently. You may have a normal androgens, etc. So this does not. So level of hirsutism does not correlate with the severity of hirsutism does not correlate with the level of androgen concentration. So, okay, so now we are in question number 8. Okay, so question number 8 is on your screens, and the question number 8 says, SAHA syndrome is a spectrum of signs and symptom of hyperandrogenism, which is not a constituent of the syndrome. Little difficult one, but as sir said, the old examiner will always ask you the hair cycles, acne, sweating, hirsutism, acanthosis nigricans, which is not a part of this. So this is a dermatological, this is not a disease, this is a syndromic presentation, which is often seen in the dermatology resident. The correct answer is sweating. Very good. So SAHA stands for seborrhea, acne, hirsutism, and acanthosis nigricans, and sweating is not a part of this. Basically, it is a dermatological presentation where you may have be able to pick up the patient with a higher insulin resistance and who may have hirsutism. And I also invoke you to go and study about hair and syndrome as well. So with this, we come to the quick check at leaderboard. And this is being done because we are at the tail end of the today's quiz, and the people who are in close fight then can catch up. And yes, still we have a close competition with Dr. Saurabh, Dr. Ayush, Dr. Himanshi, Namrata, Archit Garg, Raghavendra, Dr. Khushbu, Simran. All the best to you, and all of you can still catch up in last 1 or 2 questions which are remaining, and the time is very critical to do that. And with this, we come to question number 9 of today's quiz. And question says, so Berg scale is used for clinical classification of which of these options? So female scalp hair loss, or acanthosis nigricans, or acne vulgaris. So these are the things which need to be seen in such a presentation when patient present with hirsutism, insulin resistance, or ovulatory dysfunction, so or hyperandrogenism. So these are the things which you need to be seen, which is the what. So Berg scale, oh, sadly, many of you could not do it. So basically, acanthosis nigricans is assessed by the Berg clinical scale. And remember, it is 0 to 4, which is graded. The 4 is the severest one, where you can see from the front of the neck when you're standing in the front of the patient, and it is extended to the front of the neck, and even the thickness of that increases. And female scalp hair loss is being answered very by most of you, and that is a Ludwig scale. Please remember that is a Ludwig scale. So all these three things need to be assessed clinically, and good idea refer and go. You can go back and read about it. And this is a Berg scale, and this is a severity is given from 0 to 4 on the basis of the clinical examination. And I also, it's a good idea to today study and what is the histological features which you see when you do the histological examination of acanthosis nigricans, and papillomatosis and hyperkeratosis you may observe. So with this, we come to the next question, and this is question number 10, and question number 10 is here on your screens. So question number 10 says the lifestyle modification in PCOS can increase insulin sensitivity, decrease androgen, return to ovulatory cycles. So 30 minutes of exercise daily and 500 calories deficit per day can cause how much reduction? So these numbers may be good idea to have in a quiz maybe, but at least what I'm trying to convey is that you should remember how much efficiency such lifestyle modification can have. So 10%, so which one is the good correct options out of this? Again, many of you could not answer it correctly, and this is directly from your Williams, and it has been mentioned or quoted in many PCOS discussion, management discussion or algorithms. So 59% reduction in testosterone to SHBG ratio and 122% increase in SHBG can happen simply by lifestyle modification, and that quantity is about 30 minutes of exercise daily and 500 calories deficit of calories per day. And how much the for 7 days, if you do 500 calories reduction, how much weight reduction does it translate into? That is a question for you to go and reflect today. So this brings to us to the second last question of today's quiz, and the 11th question is here on a screen. So reverse sequential dose regimen is used for which? It is being talked in contest to which of these drugs? Spironolactone, sapropterin acetate, or levonorgestrel? So I think this is a very easy one, and because most of you would be practicing it. So this pharmacokinetic property is being talked about the sapropterin acetate in PCOS, which means that you can use this progestogen with estrogen because it is stored in the fat and released slowly, means it can be given from the initial days of the cycle itself. Spironolactone is obviously out, and levonorgestrel again is obviously out because it's androgenic, which is not used in PCOS. So next question is based on this image. Please see this image, and okay. So in the contest to PCOS, this image is referring to what? Sorry, options would be, so identify this. This is a bearded lady. So what are our options here? So what does it shows? It shows options are Harnam Kaur, Annie Jones. Which is the correct answer? A little trivia towards the end, and so apart from the bearded lady clue, there was a biggest clue which was given in the image, probably the fault from my end. But the correct answer is Annie Jones, the lady who lived in America in 1865 to 1900, and she was having a hirsutism, and she worked in circus and all the good story to read about, and she died of tuberculosis in Virginia. And the Harnam Kaur is also a lady who is who's having a world record entry for the having the maximum beard at the youngest age, and she is also having a PCOS, and she is a British citizen, Harnam Kaur. So good idea to read about. And with this, we come to the end of today's quiz, and we can have a check at leaderboard and heartbeat pounding before it's settling down, and we're looking for the top three winners, those who get the 10,000, 7,500, and 5,000 prize. Dr. Ayush is the winner with 10,157 point. Dr. Ayush, congratulations to you. We have a second runner-up, Dr. Soumya Ranjan. We have a third runner-up, Dr. Archit Garg. But all of you, Dr. Ranita, Dr. Manjuna, Dr. Shaurabh, Amanshi, Prathamesh, Namrata, Dragon Knight is a nickname. All of you did very well, and the hard luck to you. But anyways, the message was to go with a lot of learning, and I must tell you, and I feel envious today that such a beautiful academic sessions are happening where such a iconic people like Dr. Nitin Kapoor are coming and teaching you, and wish you all the best. Make a maximum utilization of this, And anyways, when we do the quiz, we need to have little selection of the winners also. So wish you congratulations to you. Please contact me for your prizes money, and all 3 top winners would be the panelists for next chapter, for the August chapter of the ESI Case Capsule. And with this, we come to the end of the today's session. Thank you, everyone. Sir, thank you, sir. Thank you for the beautiful.
Thank you so much. And Dr. Sandeep, I must put in record, you've really brought this program to a next level. Really gives me great delight to see, where it started. So really, really big congratulations. And thank you so much for having me here.
So, thanks a lot, sir. Good evening, sir.